Brilliant. So diabetes, ketoacidosis. Okay, easy, right? And essentially, biochemistry is really linking those bits together. And in med school, when we go through management of diabetic ketoacidosis, we throw things like this in your OSCEs, yeah, where basically you move from one station to the other, and we say, okay, here's the biochemistry. Tell me what you're going to do. Is that okay? Yeah. So I'm not going to go move into management, but you've got the diagnosis. Brilliant. There's a lot more over here. See, look, the urea is pretty high. Yep. Creatinine is slightly high as well. And you'll notice the sodium is also slightly high. Now, why do you think that could happen in anybody? Why should the urea go up? Yeah, absolutely. Yeah, you're getting dehydrated, right? And that's what happens in diabetic ketoacidosis. Essentially, there's severe dehydration. Yeah, and that's why your urea goes up. Yeah. Hemoconcentration, your sodium goes up. Yeah. So can you see the beautiful links which take place in clinical scenarios as well as exactly what takes place? So when you're actually studying, or if you want to basically move on from biochemistry to med school, what I would suggest is, what's the full blood count? What's the using creatinine? What's your liver function tests? What do we mean by serum and urine osmolality? Yeah. And what do we mean by pH? Yeah. See, bicarbonate's really low. Okay. Have any other sort of thing which can cause acidosis? I had an aspirin today before the class. Suppose I took about 40 aspirins, what would happen to me? Aspirin is acetyl salicylic acid. Yeah. So if I consumed a lot of acid, I'd get acidic, isn't it? So aspirin toxicity, which you're going to see in ER, is basically due to people overdosing on aspirin. Okay. Unfortunately, in ER, we also see people who basically go into acidosis because they drink antifreeze. Pretty cold outside. Yeah. You know, the cold antifreeze, that's what causes metabolic acidosis. And we see that in ER all the time. So you drink, the glycol, people do peculiar things. Yeah. Okay. And very often, Friday night syndrome, yeah, medical sort of thing. I often see this in people who basically had lots of nights out and drunk far too much alcohol. Anyway, now here's something which is pretty, very interesting, really. I had this, this was my probably second or third week in England, and I had this from a psychiatric consultant who called me back and said, hey, listen, I've got this patient who's turning blue. In medicine, as in anything else, we use big words, cyanosis, okay, blue. So essentially, look, if you guys basically decided to throttle me, upper airway obstruction, right? Or my lungs were not working properly, or a muscle was not working properly, right? Okay, you get basically cyanosed. Easy to understand? That's what medicine's really all about, basics, right? To cut a long story short, essentially, it was linked to a biochemical problem. Yeah, we could never take her off the ventilator because her muscles were not working. And the key clue over here was the creatine kinase, very, very high. Okay? And in biochemistry, as in anything else, when you get a very high, this thing is a sign of a muscle giving problems, right? What happened was basically her muscle was not working, right? And that was linked to this. So I want to show this to you. Yeah. Thanks. Thank you. Essentially, listen, guys, you're now listening to me. Your brains are using about 2 milligrams per kilogram per minute of glucose because your brain and your red blood cells depend on glucose. And glycogen basically is broken down into glucose, right? So her muscle was not working because glycogen, which is your fuel, which is sitting in the liver, yeah, essentially when it's broken down, you can look it up in your textbooks, essentially an enzyme over here was not working, right? It's called McArdle syndrome because your glycogen, the fuel, is not being converted into glucose. Yeah, okay. So that slide basically shows you a wee bit about that. See, because glycogen, the molecule itself is like this. As you keep breaking it down by certain enzymes, yeah, there's a problem there. Okay, great. Thank you, Mike. cut a long story short, we basically put in a pacemaker and her that would, start working. Okay. So in medicine, when somebody complains of weakness, it's very easy. It's a problem. Is it in the brain, upper motor neuron, spinal cord, nerve moving to the muscle? In the muscles, that's where your biochemists come in, right? Remember mitochondria. Mitochondria are your energy cells, a whole lot of syndromes, which as a clinician, I love to look for, okay? Kearns-Sayre syndrome, which is a mitochondrial cytopathy, where the patient starts talking like this, oh, doctor, I am finding it very difficult to follow, and I'm feeling weak and tired all the time. Okay? And you see bilateral ptosis, difficulty in swallowing, yeah? Okay? And medicine is all about observation and linking what you're basically going to be studying as time goes by, and that's what makes medicine so fascinating. All right? Yeah. Right here. Not uncommon. Okay? You're going to see a lot of patients like this. And this chap was told, look, you're obese. I'm sorry, if you've got weight problems, go out, eat less, exercise. Right? Till he came to our clinic. And there were certain things which made me sort of think, look, there's something else going on over here. He's not pregnant, but can you see the striae, which is abdominal stretch marks? Okay. Now there's something over here. He's been treated as a type 2 diabetic. His blood pressure is okay, but his serum potassium is low. Now, whenever we see a slight abnormality, which is taking place there with this, that's hypokalemia, and he's diabetic, right? One of the hormones which antagonizes the effect of insulin and makes you put on a lot of weight is cortisol, right? Cortisone, unfortunately, is used a lot, even outside. People just basically pop cortisone for rheumatoid arthritis. They take it for polymyalgia rheumatica, chronic obstructive lung disease, right? Lupus erythematosus, a whole lot of conditions. Now, one of the side effects of too much of cortisone is you put on weight, right? And your potassium gets dropped. But we as clinicians start thinking, he told me, look, I don't take any steroids, okay? Anabolic steroids for muscle building, nor do I take anything for this. That got us thinking. Now, cortisone is either produced with the renal cortex, which is the little Napoleon hat-like little gland which sits on top of the kidney, right? And that produces cortisol. Now, in biochemistry, you want to find out, is the cortisol coming from the adrenal gland, or is it controlled by a master gland, very important in biochemistry, the pituitary gland, right? To cut a long story short, this guy basically had an adrenal tumor, yeah? And basically, once they remove the adrenal, they do a whole lot of tests, you do scans and the rest of it and diagnose it. What I'm trying to tell you is that not all cases of weight problems are often associated with just idiopathic weight gain. There are endocrine causes of it, right? And here's a classic example of the next one, who walked into that's the tumor sitting over there. Yeah, so sitting on top of the kidneys. And so you got to be thinking, why is this guy putting on weight, and why is he diabetic, and why is his potassium low? You get it? Yeah. So the next one is a really interesting one. Look, this is before we met him, and this is after we met him, right? Again, this chap had diabetes, was overweight, and he had a tumor sitting in the pituitary gland, which is producing a huge hormone called growth hormone. So his hands became very big. He had a very deep voice. He was diabetic. And he had, look at those features. His jaw was very big. Yeah, it's got prognathism, acromegaly. Everything was enlarged. That's after treatment. It's unbelievable, isn't it? Yeah, and this is important because of something very important over here, guys. If you look at how insulin is secreted, right? Basically, it sets off glucose, which is present in you, goes via a receptor, converts to glucose 6-phosphate, and then it follows. Basically, what happens is because of this, the mitochondria, yeah, they produce a lot of ATP, which is your energy currency, right? Okay, glycolysis and the rest of it. That basically starts decreasing the conductance of potassium. That leads to sodium. There's a receptor over here. It's beautiful, isn't it? The membranes which coat your cell basically are, I'm not going to go into it because Dr. Overdoon told you a lot about it. So receptor over there, which basically depolarizes. Sodium change, calcium change, insulin comes out. However, God, nature, in his wisdom, there's a receptor over here called an SS2 receptor, which basically is blocked by another hormone which is produced by your pancreas and your gut called somatostatin. Yeah. We use this for treating that condition. It's called octreotide because it blocks the conversion of this. It blocks the conversion of growth hormone, right? So your kinases and all the rest of it over here, there is a kinase over here somewhere. There we are, okay? Which basically lead to a whole lot of changes, right? So would you understand, can you see how receptors and kinases are linked to clinical medicine? Okay, you got that? Yeah, great, thank you. So I've sort of given you a briefing. Now, it's important to understand that essentially diabetes or glucose problems actually start from a very young age. By the way, how many of you all actually had your blood pressures checked? Go on, put up your hands. Brilliant, 1, 2, yeah. Not uncommon, guys. Listen, start checking your blood pressure even below the age of 20 because there's a Stoke study which basically showed that blood pressure, just like weight control and diabetes, start from a very young age. Yeah. And in my very, very sort of 45 years of doing work in various communities, that's the problem. Those patterns of decreasing, it's your age. You must pick up these things early because comorbidities, which happen to my age, 60, 70, 80, diabetes, hypertension, chronic lung disease, all these actually start fairly young. So yeah, prevention is much, much more important than anything else. Right. You guys have been listening to me, glucose, right? In this particular, the important thing about insulin carbohydrate metabolism is this bit. Your liver is your central repose of glycogen, yeah, your fuel. Glucagon and insulin are the important hormones, yeah? Just like insulin lowers your blood sugar, glucagon raises it, yeah? We use glucagon a lot in clinical practice because we have lots and lots of patients. I've had a PhD student from the University of Warwick who was brought in hypoglycemic. Yeah? Normally, your blood sugar is between 4 to 7. Below 4, you're on the floor. Okay? It's easy to remember. What was she doing? She was a PhD, in fact, a biochemistry student, and she was trying to lose weight, and she was overdosing on insulin and metformin. Yeah, drugs which are very often, and thyroxine. Thyroxine is a drug very often misused because it makes you lose weight, increase your metabolic activity. Yeah, so and a whole lot of social factors involved. So hypoglycemia, that's what glucagon is often used for, is in the treatment of intractable hypoglycemia. Okay, it's also used in patients who've got beta block toxicity. It's a fantastic drug. Okay, right? Glucagon, 14 Nobel Prizes, including 2 from Canada. Insulin, about 5. So you can see the importance of this hormone, yeah? Because now in endocrinology, we have a whole host of problems which produce glucagon problems. Glucagenomas, lipomas, which are tumors inside your gut. It's a lovely clinical subject which basically expands the moment you start studying glucagon. Yeah, okay. Hypoglycemia is important from 2 other points of view. When you guys are going to walk out from here, yeah, if any of you are diabetic, or if I'm diabetic, yeah, the important thing is for me to check my blood sugar before I drive. Okay, so hypoglycemia, if you have an accident when you have hypoglycemic, the law doesn't sort of say, hey, that's cool because you were diabetic and you're insulin. Yeah. Secondly, as biochemists, Vincent Marks, with whom I worked with 25 years ago, basically proved a case where this count in Austria was accused of having killed his wife by injecting her with insulin. Basically, it was known his name was von Bühlen. Yeah, it was a count. It's a British guy who basically moved across. He was a scientist, and his wife was taking insulin. Now, insulin is a molecule, right, which is produced by your pancreas and consists of 2 bits. There's insulin and there's C-peptide. Okay? So if you are producing insulin by yourself, will your C-peptide levels be high or low? Yeah, agreed. Now, if I inject myself, or one of you said, hey, I need to get rid of this guy, yeah, and you gave me insulin, would my C-peptide levels be low or high? Yeah, because you need endogenous insulin is the only one which produces the C-peptide. This guy, von Bülow, was basically incarcerated in prison for almost 5 years before Professor Marx, with whom I worked in biochemistry department of medicine in Guildford, was called across, and after 5 years, the samples were there, checked, and they found out. So factitious hypoglycemia is really, really important. And as biochemists, you all will be asked time and again, hey, tell me what's going on over here. What's happening over here? Is it an insulinoma? Is it factitious? Is it drugs? We see it very often in ER, drugs. Yeah, medication. Alcohol produces hypoglycemia. And we'll push it up later. Yeah. So this slide is really important from that point of view. I'm going to move on to what happens basically after you've eaten. I'm so sorry, guys. It's 10 o'clock. So I would have given you a cookie, or given you something to eat. The moment you eat, essentially, a very important hormone produced by the L cells in your intestine. Yeah, these are called incretins, GLP-1, GLP, and GIP. Really important. These are the ones which basically promote insulin secretion. Yeah, you can look it up, but they're really important now, and very topical now, because this group of drugs is now being used for basically treating patients with weight issues. Okay, incretins is huge. It's in fact, it's very much in the news right now. Okay, so that's what controls, if you look at it, it's essentially this particular thing which stimulates the release of insulin. And the reason why that happens is, back again. Remember, glucose stimulates insulin release. Incretins from your gut, yeah? A biochemist about 20 years ago found that if you gave food as compared to glucose given intravenously, you produced more of an insulin response because what you ate stimulated the release of incretin. And incretin caused that. Is that okay? You got that? Right? So the new kids on the block for the treatment of obesity and the rest of it essentially is these group of drugs they're called exenatide. Fascinatingly, this particular thing was found from the saliva of a salamander. Right? It was a biochemist who said, look, there's a whole host of chemicals sitting over there. 30 years ago, somebody went to Indonesia, and there it was. The German guy said, what's that? He said, well, let's have a look at it. And they found that had a hypoglycemic effect. Right? So this group of drugs, exenatide, liraglutide, liraglutide, all these drugs have made a huge difference in the management of diabetes, purely from that point of view. So as a biochemist, it was actually, he was almost a medical student before he moved on, right? Okay. And what is fascinating about this group of things, because I want to concentrate on this, is that they also act on your brain. Yeah. And that's what brings me to a wee bit about, I won't talk too much about glucagon because that's the Nobel Prizes. Those are the guys who won Nobel Prizes, and insulin. Okay. And yeah. Biochemistry. Sorry for a little bit of the boring bit, okay, right? You've got to understand your metabolic pathways, yeah? The key thing is, from the clinical point of view, do you all remember a wee bit about the TCA cycle, Krebs cycle? Okay, there are two very interesting footnotes about Krebs. When he discovered the TCA cycle and he published, okay, in Nature, and the Nature editors in 1937 sent it back saying, hey, this is a whole lot of nonsense. Professor Krebs, basically, I think the University of Toronto, waived that letter about 3 months later because it was accepted. And he went on to win the Nobel Prize in medicine purely because of this, the Krebs cycle. Yeah. So you will be faced with rejection as medical or biochemists and the rest of it, but persevere, guys. Okay. If your passion is something that you believe in, study it. Yeah. Because negative results are often much more helpful than always positive results. So, facing up to rejection is a part of science. It's a part of clinical medicine. It's a part of life. So, just remember that. That was Krebs. So anyway, there we are. You have the central role of a very important hormone. I have got a lot of adipose tissue, yeah, and consists of two kinds: white adipose tissue and brown adipose tissue. Okay, I'm from India. Okay, and in India, when I worked with a professor, Professor Yagnik, he studied the amount of fat which was present in lean farmers who were working in Maharashtra, which is a state where we have lots of farmers. They looked very lean. They didn't look as if they had weight issues. And we found that it was the fat which collected in the liver which caused problems. Okay? And you've really got to understand this, because nowadays, in clinical practice in diabetes, I find more patients having liver disease due to weight issues called non-alcoholic fatty liver than, sort of infectious disease and the rest of it. Almost 45 to 50% of patients now with liver disease, fat collection there. Okay? And it's linked to this particular hormone, leptin, right? And it's linked to a whole lot of other hormones. So fatty liver is hugely, hugely important, guys. Yeah? From the... which is that, yeah. Okay? Yeah, great. Thanks. Where was I? Yeah. So the fatty liver. Yeah. Okay. So it's also important from the clinical point of view, because now we've got ways of actually stopping that fatty liver from developing. That's got to be caught really early, because once you develop fatty liver, the next stage is cirrhosis of the liver, portal encephalopathy, ascites, and a whole host of problems. Okay, so nowadays the research programs are going into leptin. They're also going into, I've talked about glucagon, yeah. They've talked about incretins. And now, if any of you are interested in liver disease, study fatty liver. Alcohol, diabetes, yeah, and patients who've got a raised BMI. Now, how good do you think the BMI is in actually calculating that you've got weight issues? No good? Okay, right. See, guys, in clinical medicine, yeah, unfortunately, that is the only parameter I can use, which is your weight divided by your height, yeah, in meters squared. Research, you go on to scans, right? And in fact, I had a radiology colleague, Amitabh, who would come in and do MRI scans, and lots of people do work, that way. But if you want to do research on that, warm calorimeters and the rest of it, it's by scans that you find out, brown tissue and, yeah, adipose tissue. So I won't harp on too much about this, except to move on to insulin signaling, which I've told you. Dr. Overdoon's told you a wee bit about kinases. See, look, your insulin receptor up there, yeah, okay, works because of a series of changes which take place by phosphorylation over here. Okay, I'm sorry to go on to the biochemistry bit of it, because leptin resistance basically is because of changes which take place here and here. Okay, and we can talk about at the end of the talk, if any of you are interested, because I want to move on. Yeah. So overnutrition leads to problems associated with inflammatory markers, cytokines, the rest of it. I won't go too much into that, except for the fact that apart from insulin signaling, sorry, we're stuck over here. Yeah, back to incretins, okay? This particular group of things is the latest sort of thing, which is last week, a drug which has basically come out. It causes almost something like 24 to 30 kilograms of weight loss in 24 weeks. Tirzepatide, okay? So why are these important, guys? If I was diabetic and you are my diabetic consultant in about a year's time, in a couple of years, what's the most important thing that I'm going to be worried about? I'm say 66 now. In about 10 years, what's going to happen to me if I'm diabetic? Give me a shout. What could happen to me? Okay, any chronic condition, especially like diabetes, yeah, I've got very tiny blood vessels in my coronary arteries which supply my heart. Yeah. Now, asymptomatic heart disease is the biggest killer in diabetes. You don't have the chest pain, you don't have the palpitations, you don't have the swelling of the feet, you don't have the ascites, you don't have raised JVP, you don't have the effort intolerance, which normally, when you go biking and the rest of it, you don't have all that because diabetes knocks off your autonomic nervous system, which is telling you what's going on. Okay, right? This group of drugs, for the first time, about 10 years ago, proved that actually using it would prevent me from having a heart attack by adding 10 years of life. In any chronic disease, what you're really worried about is, hey, listen, I am going to get those complications anyway. Diabetic nephropathy, heart disease, right? Stroke, I'm going to get them. But how far can I delay them? This group of drugs basically delays it by 10 to 20 years. So it's a game changer. So nowadays, when clinicians like myself or any research people, we go by what's known as MACE data, major adverse cardiovascular events. There's no point me giving you something which is going to lower your blood sugar, but I die anyway of a heart attack. Okay? So nowadays, if you challenge your doctor, hey, listen, why are you giving me this drug? I say, okay, right? When I put you on this drug, I'm going to prevent you from having a heart attack. I'm going to prevent heart failure. I'm going to prevent kidney disease. And that comes to a very important thing, which is basically your kidneys. So I talked a wee bit about the heart, liraglutide, semaglutide, which is now, in fact, the Americans are coming across Canada and buying up all your semaglutide, supplies. It's much cheaper over here. Okay. So the study was the LEADER-1 trial where we were involved briefly and we provided about 450 patients, but overall it was a worldwide trial which showed that major adverse cardiovascular events were reduced by that. Okay. Now, the kidneys. Why do you pass urine? Come on, biochemists.
Metabolites that are harmful?
Absolutely. Yeah. Okay. Now, strangely, when the ancient Romans and the ancient Indians discovered basically diabetes, it was finding out sugar in the urine, wasn't it? Right? Now, strangely, a very interesting German biochemist, he found out that if you used something which would get rid of sugar and linked it to sodium, you didn't die of a heart attack. Your kidneys continue to work for the next 10, 20 years. And this was obtained from the bark of an apple. Closin. Biochemistry. Closins, right? The whole group of drugs are empagliflozin, canagliflozin, okay? Dapagliflozin. How do they work? Your kidneys basically consist of the proximal tubular glomerulus. 5 liters of blood goes through the kidneys, every minute as we talk. Okay, a lot of it is filtered, a lot of it is reabsorbed. So if we block a receptor called an SGLT2 receptor in the kidneys, you promote the loss of sodium in water. When they did this, they found that diabetics were now living much longer. Kidneys were protected. Can you see the benefits of translating biochemistry into clinical science? Can you see that? How beautiful it is. It's really fascinating. So this group, if you know anybody with diabetes now, or even if he doesn't have diabetes, but has got weight issues, this group of drugs, again, delays heart failure and kidney disease by 10 to 20 years. It's absolutely brilliant. They are expensive. Sorry, I know. They are expensive. But it'll come down. Which brings me to something very interesting. When Banting and Best discovered insulin, and they gave the patent to Eli Lilly, produce insulin, can you guess how much money they asked from Eli Lilly?
No money.
Almost. Just $1. Just $1, right? And now these same companies now are charging, I won't go to social medicine, about $2,000. Americans are, they're all coming to Canada grabbing your insulin supplies. So much more cheaper there. So insulin is now produced by Gentech and genetic methods, no longer through a pig or, beef and the rest of it. So they start with the dogs. But so there's a salutary tale over there. Okay. So I'm going to pause over here because there is so much more to diabetes and the rest of it. But I want you to ask me a couple of questions because I put these slides are up for you to read, reflect on, but I've given you a very sort of brief biochemical picture about diabetes and obesity. Yeah. I've talked a wee bit about leptin resistance, and I'll move on to that slide because otherwise I won't have time, which is what happens with, I don't have time to go through exercise and the rest of it, but this is a case that we presented at the Royal College of Physicians with a person who didn't have leptin. It's rare. Okay, so the fat which we have is an endocrine organ. It produces leptin, right? And leptin stops you from eating. Yeah, this lad basically didn't have leptin. He had a receptor deficiency where the leptin was not working. So the frontiers of research which have moved into leptin is what are the genetic mutations which cause this problem? Okay. What are the receptor problems which cause this problem? And then you move on into the molecular level, kinase levels and the rest of it, because they're all linked to your G proteins and the rest of it, which you have probably studied. Am I right? Yeah, G proteins, it's all there. Yeah. So it's rare, but that's what happens, see, with treatment. So your question should be, hey, why don't we treat all patients who've got weight issues with leptin? Unfortunately, what happens with diabetes and the rest of it is you have leptin resistance because of a release of a whole lot of proteins called SOX proteins, right? We don't have time to go through it, but I'm welcome to talk about it at the end of the class. Okay, yeah. My last slide before we sort of move on to thing is, now this is something which my University of Warwick students basically did. It's a rattlesnake. And the poison which comes out from a rattlesnake is responsible for lots of biochemistry and treatment of diabetes. Okay. Your blood pressure tablet, okay, losartan, angiotensin receptor blockers, which are now the top, very, very good drugs which are used in blood, was obtained from the venom of this, yeah, Russell's viper. Biochemistry, right? Go through. That's the name of the plant, okay? And that gives you metformin, which is used in pregnancy and diabetes. Now, if any of you want to really move into the a Nobel Prize in thing, find out how metformin works. Some of the professors at Warwick still, whenever we talk about it, we still don't know how it works, but it works. Okay, maybe at the peripheral level by increasing your glucose. Yeah. Yeast. Okay. Any ideas? Okay, I'll sort of pause for a moment. That's the interesting one. The GLP-1 agonist, yeah, the salamander, yeah, poisons to the saliva from that, which is used for the management of obesity, liraglutide, right? Bark, aspirin. Secondary prevention diabetes, we use lots and lots of aspirin, okay? And last but not least, insulin, which used to be obtained from basically, it's no longer done like that. It's from the gut, pancreas. We don't do that now, it's all genetic. But the Warwick student thought about it. And the last two, really important, the apple, the humble apple, the bark of this produces flozin, empagliflozin, which lowers your blood sugar, and the fructose, which is present inside that, raises your sugar. Just imagine how beautiful nature is. Yeah, balancing one with the other. Yeah, so that's the bark of that. And these are the new kids on the block. The American Diabetes Association, as well as Canada, now we use these drugs as number one. Okay. And last but not least is, I've told you about the SGLT2 inhibitors, yeah, which are drugs which promote the release of glucose. Is that okay? So I'm going to pause for a moment over here because I would encourage you to ask me a few questions. I'm quite happy to leave these here for you. The important thing is to understand that essentially, because I don't have time, I've not had time to go through the fact that when you're exercising, yeah, you need glucose to exercise and adrenaline, yeah, and the rest of it. Epinephrine works on the release of glucose, exercise, glycogen breakdown. Okay. That's another, if any of you are interested in sports, beautiful research, which goes into glucose and the receptors and the rest of it. Is that okay? Yeah, thank you.
Any questions about any of those pathways, those proteins, those kinases, those metabolites? Please.
I just had a question. So you mentioned that the leptin resistance and so that insulin is passing like the SOX protein. So is there any like research into like making an inhibitor of those to lower the resistance or like block their action?
Now that's that good question, right? When I looked at it myself, because I didn't understand it myself, when I asked a lot of the professors, it's just one avenue of leptin resistance, SOX proteins, okay? Leptin resistance can also take place because of changes which take place in the genetics. In fact, there's a huge component in weight gain, which is almost about, I'd say, 60% in genetic mutations, right? That varies from, depending on the population that you study, the receptor which works, that leptin receptor work, I didn't have time to go through it, but I will show it to you like this. Let's say that leptin is produced, okay? It works on your hypothalamus. Anybody, sorry, is that okay? You know where the hypothalamus is? Great. Now, over there, the arcuate nucleus consists of certain arginine-producing neurons, okay, which work on your appetite center. Yeah. So leptin basically inhibits that, and it's a negative thing and reduces your appetite. Research has moved into a phase where is there a genetic mutation where the leptin receptor is not responding? It's not only SOX proteins. Okay, that's number two. And interestingly, actually, the genetic polymorphisms which are responsible for that, it's just come out last week in a paper in Lancet. If you're interested, I can give it to you, where he talks about, the leptin receptor. My PhD student worked on this, Nitya Sukumar, and she was working on SOX protein, so I brought that up, but it's just one. It's so beautiful, isn't it? Just think about it, the hypothalamus controlling your, the receptors and the kinases and,
So in the pathway where the actual leptin receptor signaling is interrupted, is it easier now in reality in clinical studies to look at overcoming that pathway or to look at cross-sensitization?
Good point. They tried doing that with glucagon. Unfortunately, when you block the glucagon receptor, because glucagon pushes up your sugar, right? The side effects of that in phase 3 trials showed that essentially you start getting liver disease. So they stopped it abruptly. That's one. The second thing was essentially when you started studying intermediate metabolism, all these drugs, remember, receptors are all over. They're not present only in the liver, the skeletal muscle, and the rest of it. I'm so sorry for using this big word. Pluripotent effects. In other words, they're working all over. And there's a very cautionary tale over here. About 8 years ago, a drug called rimonabant was used for reducing weight by blocking an opioid mu1 receptor in the brain. Unfortunately, the side effect of that was you took rimonabant, you lost weight, but you committed suicide. So there's, in the New England Journal of Medicine, when they first started talking about all these drugs, they said, look, every drug has got side effects. Liraglutide, which reduces your thing. I can't use it in patients who've got thyroid cancers. I cannot use it in a patient who's got acute, gallbladder problems. And I cannot use it in any patient who's got pancreatitis. Because these are drugs, pluripotent, they work on the brain. So what's the story? So in other words, it's a very good question because as you start studying more and more about it, you start realizing that everything in nature has got its checks and balances. So have a skeptical view about something which comes out, look at it, study it. And as a clinician, I usually, whenever I talk to my patients, I say, this is the evidence. I need to wait a lot more before I start using it in clinical practice. I'm a very cautious physician. I'd like to find out a lot more before, because drug trials, they will always say the positive bit, the negative bits. That's why negative trials are so important. Professor Hall used to often say when he was working with Avid Clinic in London, he would say, because he's worked in pharmacology and research trials and the rest of it, is that be a cautious physician and always be open with your patients. translating evidence base into clinical medicine is a huge part of what we do as secondary care, tertiary care professors or whatever. But it's up to the patient. It's up to, see, previously, you had more time with the patient. But now it's 7 minutes. 7 minutes, what can you find out about anybody? It's a tick box exercise, and you must always realize that whatever you're doing, primum non nocere, first do no harm. Yeah, the ethical principles still hang. So I think, thank you for asking that question, because, so look at, there's a good book written by a professor called Bad Medicine. It's worth reading. Yeah, so wait. And your generation does it all the time. When I was working with the COVID thing, Nightingale and the rest of it, it was difficult, but you guys were amazing. Absolutely amazing. I mean, I can say that, hand on heart. Took the load off us, and, could deal with lots and lots of problems. Okay.
We have time for one more question, maybe.
I'm so sorry, I haven't been able to go through kinases and,
Well, the slides will be available for you to see. I can put the latest slides up as well, but one more question, anybody, please? Please.
With respect to the Cushing syndrome.
Yeah.
You mentioned that they were being treated for type 2 diabetes, but actually had like hypercortisol secretion.
Yeah.
Was that causing like a pseudo diabetes, or did they have it?
Okay, thank you. Two things, yeah? Two sides of the question. One is, if I was not diabetic and I took lots and lots of steroids, either as replacement or for whatever condition, I will become diabetic. About 15% of patients who are on steroids, okay, number one. However, in Cushing, Harvey Cushing was a brilliant neurosurgeon, right? Who basically worked on where is cortisol produced. It's produced in response to stress from the adrenal gland and pituitary. So clinician then wants to find out, gosh, you're not taking exogenous steroids. You're not taking steroids. I need to find out why your cortisol levels are high. So the question that we now need to go through is it in the pituitary, the hypothalamus, or the adrenal gland? And it is fascinating trying to find that out. It's not that easy. We do a test called the dexamethasone suppression test. We do scans. We do inferior vena cava sampling, in where you basically push in a catheter and you measure the levels of ACTH in the inferior hypophyseal vein, which drains the pituitary gland. Yeah, it's not easy. And that's exactly what Harvey Cushing said. And very often when we present cases like this in an endocrine session, this is lovely to and fro, talk by various professors and medical students. Why is it this? It could be this. And sometimes we get it wrong. I had a patient once who they thought was an adrenal tumor, and the professor said, no, we need to remove the adrenal tumor. Once you remove the adrenal, you have to replace that with steroids, isn't it? Unfortunately, here was an active woman who was basically fine, cycling, doing everything. She had this adrenal problem, but after she had the thing, she had to be put on steroids. Such massive dose of steroid, I'm not kidding. She ballooned out, and then we had to use a fire truck to basically move her from home to the hospital. And so again, there's a cautionary tale over here. Whenever you ask your doctor about anything, suppose I did this, what would happen? Suppose I didn't do this, what would happen? Show me the evidence. Ask questions. We don't get it right always. Yeah, it's really important. It's worth sometimes researching it. The internet and YouTube are good, but 4 journals which I found useful: New England Journal of Medicine, Annals of Internal Medicine, Lancet, brilliant. Lancet is really, really good. I'm sure you've got, biochemistry journals, but I don't read much biochemistry, but Lancet is brilliant. And the Annals of Internal Medicine from the United States, from Sharma. But the New England Journal of Medicine is brilliant because each article, they spent about $1 million to get that peer reviewed and the rest of it. 25% of what you see on the YouTube and internet is a lot of BS. Okay. That's again being done by proper research. That came out, I think, a couple of weeks ago in the Annals of Internal. They actually sat and studied it. Yeah. So look at it again. Has it been peer reviewed? Who are the guys who are reviewing it? Yeah. So have I infused you to become doctors? We need doctors. Come on, you guys are. Yeah, okay. It's a brilliant career, folks. Honestly, I can look back on it and say, give me so much.
Thanks so much. That was a fantastic trip down a great story of a life well played and so many contributions to medicine. Amazing. Thanks you guys for coming today. See you on Friday. And do look at that table, fill out your favorite kinase, and let's start talking about your kinase and what it does to that person.
Thank you.